So it's nice to, virtually see some people. I always feel like if you have the ability to turn on cameras for these lectures, it does tend to help you keep a little bit more engaged, I think, in this like new virtual era that we've entered. So I'm Rachel Whalen. I'm one of the pediatric ENTs. I practice out in Pittsburgh. And really, I'm one of the, I think, single digit people in the country who have decided to get additional training after my ENT residency in both pediatric ENT, and then also I did a sleep medicine fellowship. I did the pediatric track CHOP and University of Penn fellowship 2 years ago. And so my clinical practice in Pittsburgh, I work on the children's as well as I do some adult sleep surgery. So I really do sleep surgery and kind of focus on sleep disorders for children as well as adults. So it's somewhat of a unique practice. And really my goal for today is to be able to give you a sense of how we as sleep surgeons evaluate children with sleep apnea and how we think about different treatment options. So, really, the objectives for today are to discuss really how, as a sleep surgeon, you think about the upper airway anatomy. And particularly for this talk, we'll be talking about children in terms of how we associate anatomy to OSA risk. And then how do we decide, decision-making pathways? So who gets a sleep study? We'll talk a little bit about the guidelines for that we have. And then what are the different treatment options and what evidence do we have out there to support that decision-making process? So again, we'll just go over some anatomy and kind of an overview of pediatric sleep apnea, talk about how I think about an upper airway evaluation, when I get sleep studies, when you should get sleep studies, and then we'll talk about a treatment overview. And if there's some time at the end, like to touch on the role of sleep endoscopy. You'll probably, see patients with these refractory or very severe cases who, if you're at more tertiary centers, will consider a sleep endoscopy. And then we'll also touch on patient populations in terms of Down syndrome and Inspire implantation. So I think that, the first thing that if you think back to medical school, and we all start our pediatric rotation, and the first thing that's like drilled into us is that children are not just little adults. And I think that really rings true when it comes to evaluating the upper airway. When we look at pediatric airways compared to adults, tends to be, starting really at the level of the tongue. It's not that the tongue is necessarily too large, it's that the tongue grows before the container. And so you end up getting this relative macroglossia just because the craniofacial skeleton generally takes a little bit longer to catch up in terms of size. And then, as we know, the cartilages in children tend to take some time to mature. So you end up with soft malastic tissue at the level of the epiglottis, and then also the supraglottis, as well as down into the trachea. Similarly, when we think about where the airway narrows the most, we know that the level of the vocal folds tends to be the most narrow portion of the upper airway in adults, and in children, it's the subglottis and really that level of the cricoid. And we know that looking, I think the Olsen twins are a nice example of things that are one way in childhood, sometimes change quite a bit in adulthood. And so they're perhaps, a corny example of how pediatrics is quite different than adult anatomy sometimes. In terms of really looking at the airway anatomy from a sleep standpoint, the other kind of, I think this picture kind of nicely demonstrates even just the, size and shape of the occiput kind of puts children in kind of some degree of flexion when it comes to, what it does to the level of the upper airway. And so a neutral, quote unquote, neutral position for children sometimes is actually still a little bit restrictive from an upper airway standpoint. So when we look at kind of sleep architecture and sleep parameters in otherwise healthy children, this also differs compared to adults. And so some of this is kind of board testable stuff. But, you know, a lot of it kind of just intuitively makes sense. When you look at sleep efficiency in children, obviously there's pretty large variability, but this tends to be more efficient than in adults. They tend to fall asleep quicker and sleep ideally for longer stretches at a time. There also tends to be decreased REM latency and decreased sleep latency when compared to adults. And as children hit kind of teenage years, this tends to start resembling adult parameters. And when we look specifically at pediatric sleep disordered breathing and sleep apnea, lots of infants and children snore. Part of my practice is, you know, yes, I focus on pediatric sleep, but I do the whole realm of pediatric otolaryngology care. And so in any general pediatric clinic, you see tons and tons of kids that have snoring and kind of, they're somewhere on this spectrum of sleep disordered breathing. And we know that most of the time, or at least we think most of the time, snoring in and of itself is not pathologic and does not, you know, lead to associated health risks. A lot of what we end up treating is kind of this quality of sleep, quality of daytime function kind of parameters. And so while up to a quarter of otherwise healthy infants and children snore, we know that somewhere probably closer to the range, you know, more recent data is showing perhaps 4 to 5% of children actually have some degree of sleep apnea. Probably, you know, that variability comes into play when you talk about where do you actually define the cutoff to start calling it sleep apnea versus this, you know, more borderline or very mild sleep apnea. In Pittsburgh, at least, we tend to use an AHI of 2 as like the hard and fast, no sleep apnea if it's less than 2, and then 2 to 3 is kind of this borderline, very mild range. Also, when we look at risk factors for sleep apnea, Hispanic or African American race, any kind of craniofacial anomalies or genetic syndromes, neuromuscular disease or restrictive lung disease at all, obesity, as well as prematurity come into play. So when we talk about, you know, kind of looking at signs and symptoms of pediatric sleep apnea, they tend to be, you know, at least to some degree, a little bit different than when we picture an adult with sleep apnea. So when you picture an adult with sleep apnea, you picture, you know, super overweight man that's falling asleep at the wheel most of the time. And obviously, you know, as sleep practitioners, we now know that that is sometimes the case, but very much oftentimes in adults, not necessarily the case. And I would say on the pediatric side, we tend to see it quite the opposite more frequently. So rather than being tired during the day, a lot of times kids actually end up with daytime hyperactivity, a lot of behavioral concerns that arise both at home and in the school settings, much more commonly than, you know, the picture of somebody kind of falling asleep. In terms of nighttime symptoms, we always assess for, you know, restless sleep, excessive sweating during the night, and also concerns for bedwetting. Obviously, in younger children, a lot of times, you know, you have to kind of suss out, is this primary bedwetting in terms of, have they ever had a period of time that they were dry and then did they start wetting the bed again? Or is it just that, you know, when you potty train, it's kind of the last part to fall into place. In very extreme cases, you can have some concerns arise in terms of failure to thrive if really all the caloric expense is going towards just trying to breathe at night. Obviously, small children, premature infants are more at risk for this failure to thrive picture. It's pretty rare that we see that in anybody, you know, over the age of infancy. And then, you know, when you look at studies, looking to see how good are parents and caregivers in terms of, can they assess when there is sleep apnea versus snoring. And really, you know, the positive predictive value in terms of, are they good at that assessment or not, is really variable. We don't have any good evidence to say, you know, that if when parents come in and they say they're really not sure if there's pauses or stops, it's really hard for us to tell without a sleep study. A lot of times in the adult world, I feel like you see these patients and the bed partner can give a very good history. In children, you know, that makes sense, right? Because we know that from a PSG standpoint, a lot of times these events are oftentimes more subtle. They're more hypopnea driven rather than apnea driven. So it's not surprising that families have this kind of more difficult time differentiating snoring versus obstruction. So, so getting into kind of how we think about the upper airway from an ENT side of things, really what I'm trying to assess for is there an identifiable site of collapse or obstruction that I can see on exam? So obviously, you know, we all look in the back of the throat and look to see tonsil size. A lot of times when you're looking in the mouth, you also can see what is the craniofacial skeleton and what's that relationship to the size of the tongue? Does the tongue have lateral ridging on it? Is the tongue sitting high above the occlusal plane of the teeth, suggesting that, you know, it's not going to be able to fit nicely in the roof of the mouth and definitely contribute to obstruction at nighttime. The other kind of components of the physical exam in pediatric patients is generally comprised of an adenoid evaluation. We can evaluate adenoids in the back of the nose really one of two ways. Either get a lateral X-ray looking to see, you know, is there a soft tissue density that we can see at the level of the nasopharynx, or, you know, as long as you can kind of hold the kid down gently and parents are okay with about 30 seconds of crying, we usually just use a flexible scope to take a peek to the back of the nose in the clinic setting. And so really, you know, we're assessing the airway really from the tip of the nose to the level of the glottis. So in terms of, you know, who we decide to get a sleep study in versus, you know, you see this kid with snoring and possible pauses, who do we say, let's get a sleep study versus who do we say, let's go ahead and just offer an upfront adenotonsillectomy? And I would say that, you know, in this kind of era of shared decision-making, this is certainly an area where that definitely comes into play with families. You are oftentimes making a decision together. You know, occasionally, of course, you know, this picture is kind of a dramatic example, but when you look in the back of the throat, if a child has symptoms and you look back there and the tonsils look like this, you know, clear 4+ tonsils, then I would say, unless you're really worried about other comorbidities and whatnot, then this one is certainly a good example of somebody that you just offer upfront surgical management. So our academy, the Academy of Otolaryngology, actually has a clinical practice guideline to say who should we be getting sleep studies on before tonsillectomy. And so in general, the children that we tend to have a push to get a sleep study on are children with obesity. Really, I would say any kind of syndromic children, but certainly Down's kids. At our institution, at least everyone by age 5, I think is the national guideline, with Down syndrome should get a sleep study, even in the absence of symptoms. Most of the time there's at least snoring, and so the Down's kids end up getting sleep studies before that age anyway. And then as we talked about, you know, kind of risk factors for having sleep apnea, neuromuscular disease, it's also recommended for sickle cell and mucopolysaccharidoses. All of these children, we have a pretty low threshold to go ahead and always get a sleep study before surgery. And then, you know, the academy kind of gives this option of, well, advocating for a PSG, but it's not necessarily, you know, strictly indicated, is any time that that the symptoms are either unclear severity or there's a discrepancy between tonsil size. So, you know, like I was saying, when you look back there and just the whole oropharynx is filled with tonsil tissue, that patient, you know, is probably going to benefit from having the tonsils removed. If you look back there and the tonsils are 1 or 2+, it's harder for us to get excited about that. But we'll touch on, you know, the data, which is a good segue here. You know, interestingly, even when children have smaller sized tonsils and symptoms of sleep disordered breathing, you know, it's harder for us to imagine those tonsils really causing a lot of obstruction. Interestingly, though, this has never really totally panned out in terms of the literature. What we do know is, so, you know, this was a study, kind of a nice study looking at different tonsil size, 2, 3, 4 size plus tonsils, in terms of after children undergo adenotonsillectomy, who has better improvement. And really, the first kind of note was that there was really not a good correlation between adenotonsillar hypertrophy, the size of the tissue, and baseline OSA severity. And everybody got better. And so, it's kind of interesting for us because I think, on the medical side as well as the surgical side, when we see these kids and you look in the back of the throat, everybody's like, oh, there's 4+ tonsils. This is going to help. When there's 2+ tonsils, we get a little bit less excited. And so it's interesting to kind of look at the data, I think. Maybe, that kind of gut feeling pans out to some degree. But when you look at these numbers, so in terms of like who got better, this was like, they considered resolution to be an AHI of less than 2. These are the numbers for 2, 3, and 4+ tonsils. And so, so when you look at strictly cure rates, I mean, nobody, this was not an overwhelming cure rate regardless of tonsil size, which is interesting, perhaps this was a little bit less effective in the 2+ tonsils, but 25%, resolution rate compared to 36% in the 4+ tonsils. I don't know what to do with that data other than to say perhaps we should have just a high index of suspicion, even for children that have 2 and 3+ size tonsils, not just the 4s. And then the kind of big study that came out in the past 5 to 10 years has been the CHAT study, which usually, whenever somebody's talking about pediatric sleep apnea, you'd be remiss to not bring up the CHAT study, I think. It was a big randomized control trial looking at healthy school-age children with sleep apnea. And what was interesting is, these children were randomized either to upfront adenotonsillectomy or a 6-month period of watch and wait, where, allergies, comorbid asthma were controlled, but the tonsils and adenoids were not addressed. And then everybody got sleep studies at 6 months post. And interestingly, there was really not a huge difference in terms of the primary outcome measures between the children that had watchful waiting versus the children with upfront surgery. So the primary outcome measures were executive function and attention testing. There's really no difference between groups. Everybody, what was interesting, tended to get a little bit better. And when you looked at kind of resolution of sleep apnea, about 80% of kids that underwent adenotonsillectomy and almost 50% of kids that did not undergo adenotonsillectomy ended up having a sleep study that kind of panned out into the normal range. And so this was really surprising to a lot of people, right? Like, why would almost half of kids get totally better or, have at least resolution without undergoing a surgical intervention, and kind of made everyone take a step back and say, well, are we operating on a lot of these kids unnecessarily? And the other kind of surprising, thing that the study brought up was that the most notable improvements that we saw were actually in obese children. And usually from the surgical side of things, and also, our medical colleagues tend to overall get less excited about taking out tonsils in obese children because, the overwhelming thought is that, well, they're going to be at such high risk for residual OSA, and perhaps, we'll need the CPAP anyway. So is it really worthwhile? And this study suggested that, yes, it's worthwhile. In terms of, there's been a lot of commentary after the study talking about how to kind of explain this difference in resolution rate of sleep apnea. And a lot of the thought is that perhaps that because most of the children in the study had very mild sleep apnea, that perhaps it was just they were being caught on a slightly different night. And so if their baseline AHI was 3 or 4, well, then maybe it was, 1 to 2 this time. So, perhaps that offers some degree of explanation. But what this tells me really is that this is this mild OSA range particularly is a really good opportunity for this shared conversation with the family. And so, so I will either offer usually upfront adenotonsillectomy or the option to treat for allergies, treat comorbid asthma if it's there, and reassess in a few months and see what's happening with symptoms. And I think this data really supports that that's a reasonable option to consider. So, in terms of tonsillectomy and kind of, what we talk about with families when we're having this preoperative discussion, obviously the big risk with taking out tonsils is that there's a risk of a post-tonsillectomy bleed. That risk is about a 5% risk of bleeding. And, I think the most important thing that we discuss with families is really what's the goal of surgery. And so for children with mild, moderate sleep apnea, I do generally talk about that ideally we will get a cure, resolution of sleep apnea. However, for children, particularly with more severe sleep apnea or additional concerns, craniofacial syndromes, hypotonia issues, lung issues, then perhaps we're really just going for, kind of improvement rather than cure. And so you want to set the expectation that if there's residual sleep apnea, it still may need to be treated despite surgery. And then, looking at kind of the next step, you take the tonsils out, and then how do you make the decision, are children safe to go home versus be admitted postoperatively? And, are there any pulmonology trained fellows on the call? Does anybody know the complication? Why do we really think about admitting kids after tonsillectomy?
Post-obstructive pulmonary edema.
Yay! Yeah, that's right. So the pulmonary people probably know a lot more about this than I do. But I can tell you, when we think about post-obstructive pulmonary edema, basically what happens is you have this site of obstruction at the level of the upper airway, and you take that obstruction away, and then all of a sudden these children are still kind of pulling all of that air down. It decreases your intrathoracic pressure, venous return goes up, and then basically you get this influx of hydrostatic pressure, which ends up going into the lungs. And so I can tell you that I've had several cases of post-obstructive pulmonary edema. It generally happens within the first few hours after surgery. One of my partners actually had a case last year where they literally extubated, and the child took a few deep breaths and then started like foaming out of the mouth because it was that extreme. And they got a chest x-ray still in the OR, and it showed really, really significant pulmonary edema. And so in terms of treatment, most of the time we just kind of observe in the ICU, limit fluids. Occasionally you can use positive pressure therapy if it's very pronounced, and generally it takes a couple of days and some gentle diuresis, and these kids get better. But really that's the reason that we think about admission post-op. So our guidelines in terms of who we kind of hard and fast tend to admit post-op, anybody with severe sleep apnea or significant oxygen desaturation on a pre-op sleep study, young children, and then I would say just any syndromic children in general tend to be a little bit more on the fragile side. So talking about, kind of additional treatment options besides tonsillectomy, since I'm sure you guys have now heard enough about tonsillectomy for like the next few months of your life. So, in terms of, what we think about for medical treatment options, as I mentioned, this is a really nice place. This borderline mild sleep apnea is a really nice space to talk about really medical treatment of snoring and sleep disordered breathing. And when you look at kind of studies, there are quality of life studies and pre and post PSG studies. The results are variable, but overall suggestive that it at least warrants a try. So like I said, usually I'll, give this option to families if the sleep study does show just a mild degree or this kind of borderline picture. And I have plenty of families that are very happy with that option. And they do feel like overall daytime function and sleep quality are improved with medical therapy. In terms of medication options, usually, you know, as nose doctors, we tend to like a nasal steroid spray. There's really good evidence to suggest that nasal steroid sprays really help from an allergic and a sinonasal inflammation standpoint. And so, you know, the concerns in children, of course, with any kind of steroid is, you know, is there going to be any deleterious effects from a growth standpoint? And there have been studies done looking at intranasal corticosteroids, specifically looking at Flonase use, that suggests there's no difference in terms of growth velocity, and really no adverse effects. What I'll say is that there's no great evidence this increases the risk of epistaxis, but anecdotally, I see it enough that I do warn families that if they're starting a nasal steroid spray, just be on the lookout. It can dry out the nasal mucosa. For families or for children that are already growth restricted for whatever the reason, sometimes Nasonex is a nice option because it does have the lowest systemic bioavailability, although the systemic absorption for all of these nasal steroids is really, really minimal. And then, you know, the other kind of medication option that we tend to like is the use of Singulair. It has particularly good efficacy for children with comorbid asthma and allergy. The thing to know is that you do have to counsel families regarding a black box warning for a potential risk of psychiatric disturbance. There's been several reports of suicidal ideation. So I actually do not prescribe it in any children with a history of depression or anxiety. I tend to avoid it in teenagers. I tend to use it more so in school-age children who are otherwise healthy and do not have a psychiatric history. And then I always tell family, if there's any concerns at all, then just go ahead and stop the medication and please call and let me know. And to date, I have had one family call and say that it seemed to increase hyperactivity, which who knows, and they stopped use, but I have not had issues with from a neuropsychiatric standpoint. And then, you know, really what we don't have a good sense for is when you start people on medicines, how long are we supposed to continue the medicines? Is this something that is, you know, kind of chronic maintenance medication? Usually what I'll do is give them a course of about 3 months. Most of the studies, you know, that use medical trials or medication trials look at about a 12-week course. And so usually what I'll do is about 12 weeks. And then if we're treating kind of an allergy component, I'll say, you know, get through spring, for example, and then kind of taper once all the pollen hits, or get through fall. And then once ragweed kind of dies out, then go ahead and try to taper things off. You know, in terms of looking at other non-surgical treatment options, obviously CPAP and BiPAP are options with, I would say, variable success depending on the study and the center. And honestly, probably depending on if you have a behavioral sleep person who can work with children, work with families, and increase compliance, comfort, and fit. In craniofacial children, mask fit becomes an issue. I know when I was at CHOP, there was some work being done looking at, overall like 3D printing to specifically, you know, shape a mask to each child's face, which has not made its way to Pittsburgh quite yet, but I think it's a great idea for these craniofacial children with really significant sleep apnea. You know, there's limited evidence to suggest that maybe it's possible to create some craniofacial change. So if you do treat young children that you're going to recommend CPAP for, it's something to at least discuss with the family, I think. And then, you know, obviously in very little babies, it's just, you know, sometimes becomes a feasibility issue. In toddlers and young children, families are generally pretty hesitant just from a acceptance standpoint. But like I say, you know, I would say referring to a good behavioral sleep team to really work with families in terms of acclimating to CPAP, it's sometimes a really good option to consider still. And then, the other, what I consider kind of underutilized treatment option that we're still, I think, just starting to really understand is really this rapid maxillary expansion. And I actually think that probably the skeletal structure is really the key to sleep apnea prevention in the future, because if your tongue does not have somewhere good to sit in the roof of your mouth, it's going to just fall back. And so, a lot of times when we see these kind of early teen year children, hopefully we see them before they've kind of missed the window to be referred for orthodontics and really expand their maxilla. In terms of, when that suture line fuses, it really it's person specific. It's kind of orthodontist specific in terms of how willing they are to really try that expansion. Some people use the age of 13 to 15 as kind of when those palatal sutures fuse in the midline. And so if they've already fused in the midline for these older teenagers or young adults, then something, it would require surgically splitting that suture line. So talking about, just touching on the other kind of surgical treatment options that we consider. These are things that sometimes is nice to, have a picture to actually see what the anatomy looks like a little bit. So, addressing the nasal airway, we essentially extrapolate a lot of our evidence from the adult world. And really what the adult literature suggests is that this can have a role for making a difference in terms of nasal breathing, daytime breathing, and also quality of sleep. Even if the goal is not necessarily to cure the sleep apnea, it tends to make other treatment options more comfortable and more effective. So in the children population, tend to use this for children that you really suspect an allergic component, and you look in the nose and there's these huge boggy turbinates. There is some study data suggesting that there's improved quality of sleep, quality of daytime function, and then decreased use of the need for long-term medications like nasal steroid sprays postoperatively. Another kind of surgical site that we consider, and mainly, these other treatment options are the options that we tend to consider after adenotonsillectomy has failed, are addressing the lingual tonsils, the tissue at the very back of the tongue. Here's a nice kind of before and after picture. You can see that when there's lingual tonsillar hypertrophy, it does tend to have this secondary effect of pushing the epiglottis. And most of the time, there's rarely also an epiglottic component separately. Most of the time, if you adequately decompress the lingual tonsil tissue, then the epiglottis will lay nice and flat. Sometimes the epiglottis itself is the problem, in which case we can do either an epiglottoplasty, where a portion of the epiglottis is removed entirely, and or an epiglottopexy, where you essentially pexy the epiglottis to the base of the tongue. When you're dealing with kind of lingual tonsil tissue, epiglottopexy, plasty, you always have to, of course, talk about risks for dysphagia. But I can say that as long as you are not too judicious in terms of taking all of the epiglottis, generally for otherwise healthy children, there tends to not be a concern in terms of aspiration risk post-op. And then, sometimes laryngomalacia, kind of this floppiness of the tissue above the voice box, is an issue. And so to address that, sometimes we'll perform a supraglottoplasty in terms of impacting both daytime breathing as well as sleep apnea. And so you can see here, what we do in a supraglottoplasty is trim the tissue of the arytenoids, which you can see in kind of the pre and post-op pictures, and then release these aryepiglottic folds. And so the goal is really just to allow the supraglottic structures to kind of unfurl so that you don't have as much tethering and obstruction at the level of the supraglottis. And then, I would say in the past 10 years or so, we've really moved away from tracheotomy. People tend to think about this kind of as like a last line or a, almost like a failure for sleep apnea. But I can tell you that for sometimes, syndromic children or children that are going to need to go multiple procedures in the future, sometimes a trach is a reasonable consideration, either for a temporary period of time or for long-term purposes. So the other thing I wanted to kind of touch on today was the utility and the role of drug-induced sleep endoscopy in children. Sleep endoscopy is a nice tool. We certainly use it on the ped side as well as the adult side. And it can really help you guide either current or future decision-making. Obviously, the downside is that it requires time, resources, and anesthesia. And we have this kind of VOTE classification system, the velum, the oropharynx, the tongue base, and the epiglottis in adults. And we know that in children, if you remember from my initial slide, that classification system is not easily translatable, meaning there are additional sites of obstruction that needs to be considered for children. So there have been several groups that have kind of put together their own scoring systems for pediatric sleep endoscopy. And I'm not sure we have a great consensus. It's still kind of user dependent, but I would say I like this one because in general, these are the sites that I think about as being important for pediatric sleep apnea. So starting, superiorly at the level of the adenoids, and then the soft palate, the velum, the lateral walls and the tonsils, and then looking at the tongue base, and then the supraglottis, as well as, I think about the supraglottic structures, and then the epiglottis as kind of a separate supraglottic structure. And, when people, I think, are still trying to figure out what is really the role for sleep endoscopy in children. And so this was kind of a nice study that looked at how does awake tonsil size compare to the degree of obstruction on a sleep endoscopy, and how does that compare to sleep studies? So where does this kind of fit into our paradigm? And so not entirely surprising, super little and super big tonsils correlated really well to sleep endoscopy, meaning 4+ tonsils collapse and cause an issue. 1+ tonsils rarely do. But, kind of perhaps not surprisingly, this intermediate grade tonsils, these 2+, 3+ tonsils that we see, and we're not really sure how representative, those are to suggest sleep apnea. The DICE was much more helpful in terms of predicting PSG severity. So, so sometimes, a nice adjunct to use in the OR. I can tell you that in my practice, I tend to use it for children with sometimes very small tonsils to confirm tonsillar collapse. If they have a bad sleep study, but very small tonsils, I'll do a sleep endoscopy and tell family that I'll err on the side of taking the tonsils. And then I'll just confirm with the sleep endoscopy that they are in fact part of the problem. For children that are medically complex, or children that I really think are going to be at high risk for residual sleep apnea even after adenotonsillectomy, those are the children that I'm really using sleep endoscopy for currently. And then the last few minutes here, I figured I would touch and just kind of give you the updates in terms of where we are from an Inspire standpoint for pediatric patients. And basically when it comes to this, to children with refractory sleep apnea or residual sleep apnea, tends to be kind of the algorithm that we follow. Children get an adenotonsillectomy, and then if they're failing, we consider a sleep endoscopy to look for other surgical targets, take the lingual tonsils down if they're large and part of the problem, address any other soft tissue, or even consider palatal expansion or skeletal surgery. And then, what are there any other options? And I think that's really, this is really the place where hypoglossal neurostimulation potentially fits in. So as you may know, the first kind of group of children that this is really being looked at in a systematic way is the Down syndrome population. And this is potentially a really good target for this therapy because of the degree of hypotonia, and also the fact that there is relative macroglossia in these children. And so pushing the tongue, forward is potentially going to be a really nice therapeutic option. So in terms of published data so far, the kind of published data has been on 20 adolescents with Down syndrome that were implanted, and I think 5 different sites across the country. And in Pittsburgh, we are one of those sites. And so it's been kind of exciting over the past few years. And you see, looking at objective pre and post-op AHI scores, significant improvement. There also seems to be, from parental report, improved speech, cognition, school performance, and overall daytime functioning. There's been some question, why would speech get better? Is it just from a neurocognition standpoint, or is it from like actual strengthening of the tongue? To some degree, maybe it's being kind of worked out when the therapy is working overnight. I don't know. I think to be determined on that one. In terms of, drawbacks that we consider for children considering an implant like this, the current iterations, we think the battery usually lasts somewhere in the 10-year range. Maybe you get 15 years out of it, but certainly, they'll require battery changes, surgical battery changes every decade or so. So, when we're implanting people in their, 60s, 70s, 80s, not that big of a deal. But when you're talking about a teenager with Down syndrome, then perhaps, hopefully, significantly more battery changes over their lifetime. Also, you can imagine you have the electrode around the hypoglossal nerve under the chin, and then you have the pulse generator, the actual device implanted in the chest wall, and a wire between the two of them. And so, yes, there's some slack in the wire, but, as children grow, as the neck and the chest grows, will there be scar tissue that forms, or will that wire become a problem at all? And then I did just want to touch on, there were some concerns for the earlier generations of these devices about MRI compatibility, and the most current iteration was cleared for full body MRI compatibility. So thankfully that one isn't a huge issue anymore. So currently there's really 2 big trials going on in Inspire for pediatric patients. The first is kind of a deeper dive looking at neurocognitive outcomes of Down syndrome who are implanted. And I think there's 5 sites across the country. We're one of the sites looking at kind of pretty in-depth executive function, neurocognitive outcomes pre and post-operatively. And then there's also a registry that we're one of the sites for, looking at young adults basically who are implanted with Inspire therapy, looking at kind of their 5-year track record. I can say that study is, more difficult to enroll for right now, because obviously, most young adults ages 18 to 21 are not going to jump to, we're not going to jump to an Inspire implant for them. That being said, I think the cerebral palsy population is probably a good target for this therapy as well. I had a 19-year-old that I implanted last week, and so she'll be activated in a couple of weeks. So I'll have to, keep you posted in terms of how she does post-operatively. But some exciting work going on to really see how this therapy can be translated to the pediatric world. So I know that was kind of a whirlwind talk about, how we think about pediatric sleep apnea from the ENT side of things. But, really what we try to do is pinpoint the site of obstruction or collapse. And really, if you can find where children are collapsing, you can generally make them better. And I think we're still figuring out, the role of sleep endoscopy and different surgical treatment options for pediatric sleep apnea. It's kind of an exciting field because, there's so much work that still has to be done. And then oftentimes, this is really a disease process that benefits from a true multidisciplinary approach, particularly for these more medically complex children. So I think pediatric sleep is a great field. If anybody is close to Pittsburgh or wants to come spend some time in Pittsburgh and see my sleep practice, I'd love to have you. And I'm happy to take any questions. I figured I could shamelessly put pictures of my children sleeping. It's a little bit of a stretch, but it's a sleep talk, so I guess I'm allowed. But I'm happy to take any questions anyone has, and thanks for listening this morning.
Thank you, Dr. Whalen. If anyone has questions, you can just unmute yourself and ask, or you can put them in the chat.
Hi, Dr. Whalen. My name is Ian. I'm one of the sleep medicine fellows at Stanford. I was just curious about your experience. I read the initial report of 20 patients. It seems really positive. I feel like that's really different than I feel like what our experience sometimes is with adult patients that get Inspire. Is that kind of reflect what your experience is, that it seems to work really well in this Down syndrome population?
Hi, Ian. You're at like the mecca of sleep surgery at Stanford. So that's a really great question. And so far, the thing is, there's 20 patients, right? So it's such a smaller sample size. It does seem like anecdotally, these patients are actually responding better than the adults. Yes, that's been our experience, at least with, I think 4 total patients that we've implanted so far at our site in Pittsburgh. But I think part of it is, the Down syndrome trial that we're doing right now has pretty stringent BMI criteria as well. And so a lot of the true Down syndrome kids, have a BMI that is above the 95th percentile for otherwise, otherwise healthy children of that age. And so most Down syndrome children are disqualified from a BMI standpoint. So I think to some degree, as practitioners, we're a little bit concerned that this is overrepresenting, the true effect if we were just to say, okay, well, children with Down syndrome qualify for this if they fail adenotonsillectomy and CPAP. So I think, because we're selecting such a select group for the trial, I think the results are a little bit more promising than they might pan out to be in future years. I don't think our Pittsburgh sleep fellows are on the call. That's okay. They've already heard this talk. All right, guys.
Hi, Dr. Whalen. This is Dr. Gupta from JFK Medical Center in Edison. Very interesting talk. And I was curious about your criteria for admitting post-surgery. And it mentioned children under 3 years. Mm-hmm. So what are the particular concerns in that age group?
It's a great question. I don't think we have great evidence. Part of why we tend to admit those children is because we tend to not like to take out tonsils until kids are at least 3 from the risk of bleeding. If they were to have a post-tonsillectomy bleed, just from an overall size standpoint, we tend to worry that it would be more critical. So we just have a lower threshold to just really go slow with those children. But a lot of practitioners like to get a hard and fast rule sleep study first if you're going to consider taking tonsils out under 3. And really we admit for that same reason, the risk of bleeding.
So the reason why I ask is, should we make that recommendation routinely in our reports when we are studying under 3 years old in the lab, that if tonsillectomy is being considered, then post observation is advised?
I don't think it's necessary, because I don't think it's really related to the sleep apnea or post-obstructive pulmonary edema concerns. So I think because it's, more surgeon concern, I would probably opt to leave it out of the reports.
So it can be based on the surgeon's preference if they want to observe or not.
Yes.
So
but I would say most centers do.
I see. So is there any reference, like any like a guideline or reference that we can use to help?
That's a good question. I don't know if I have, I can look, I can send to you if I'm trying to remember if because we have clinical guidelines to suggest to get a sleep study for children before adenotonsillectomy under 3. But I don't know if we have guidelines to say to admit postoperatively.
I see. Okay, thank you so much.
Of course. All right. Well, thank you all for listening and for thoughtful questions. And Sally, thanks for getting everything set up. I appreciate it.
Thank you, Dr. Whalen. You gave a wonderful presentation and we appreciate it. And thanks to everyone who attended. And we will see you next month. Thank you so much. Take care.
Bye-bye.
Thank you. Bye.